For evidence that matters in nuclear medicine, follow me.
Mapping cellular metabolism reveals the true extent of disease, guiding targeted therapy. Inflammation can remain invisible.
The true target of this disease is not the blood flowing through the artery, where inflammation silently develops long before irreversible damage becomes visible. Patients rarely present with a single defining symptom. Headache, fatigue, fever, or weight loss may appear unrelated. Yet behind these common complaints, clinical suspicion may raise the question. Molecular imaging can add another layer, showing where inflammation is active throughout the vascular beyond what symptoms alone can reveal. Before the tracer reveals inflammation, preparation matters. Fasting, hydration, and controlled conditions help reduce physiological uptake and improve image quality. Timing matters too. After injection, a standardized uptake period allows the tracer to distribute before imaging, improving consistency and helping us interpret. Interpretation is not simply about intensity. We assess distribution, pattern, and metabolic activity in anatomical context, distinguishing In active large vessel vasculitis, uptake typically follows the arterial wall, producing a smooth, linear pattern along the aorta and its major branches. But vascular inflammation should never be interpreted in isolation. A whole-body assessment reveals the distribution of arterial involvement and helps distinguish disease-unrelated findings. The next question is not simply whether uptake is present. We assess intensity and distribution, the extent of vascular involvement, and its significance in the clinical context. But beware the pitfalls. Atherosclerosis and adjacent physiological uptake can mimic vascular inflammation. Anomical correlation and the uptake pattern are essential. But bewares can mislead. Physiological activity in the heart, muscles, or other adjacent structures may appear close to vessels. First, localize the uptake, then interpret the pattern. Once the images are reviewed, the findings must be translated into a clinical report, where the uptake is, what pattern it follows, and how extensive the vascular involvement appears. Interpretation is not simply about intensity. We assess distribution, pattern, and metabolic activity in anatomical context. Timing matters too. After injection, a standardized uptake period allows the tracer to distribute before imaging, improving consistency. A structured report turns complex imaging into actionable information. Distribution, pattern, and extent, with clear correlation to the clinical context. The value of PET is not the image itself. By revealing the distribution and extent of active vascular inflammation, it can add information that helps guide clinical assessment and management. But imaging should never stand alone. Its clinical value depends on evidence, validated imaging principles, published data, and guidelines that place each finding into context. The imaging should never stand alone. FDG PET can reveal the distribution of active vascular inflammation beyond what anatomy alone can show. For evidence that matters in nuclear medicine, follow me.